Welcome to this session. My name is Elena Martinez. I'm the technical manager for this session entitled Cash Programming to Prevent Acute Malnutrition in Emergencies, Evidence and Emerging Practices to Support Optimal Design. Now, I would like to pass it over to our wonderful session facilitators. We'll start with Geraldine. So passing it over to you, Geraldine.
So good morning, good afternoon, everyone. Very welcome to this online learning lab session on cash programming to prevent acute malnutrition in emergencies. We are very pleased to be with you today, joining from all over the world. My name is Geraldine Hunton. I'm a nutritionist, and I've been working for WFP in the nutrition division in Rome headquarters for 7 years now, mainly on nutrition sensitive programming and more recently on cash for prevention of acute malnutrition in emergencies. Today, I'm with my WFP colleagues, 3 of them, and they will be helping me facilitating this interactive session. I will briefly introduce themselves now. So we have Dexter Chagwena. He is our SBC specialist, and he has been working on all the social behavior change components within that cash for prevention of acute malnutrition programming. I'm also with Chris Coffey, that is our data and let's say food systems and nutrition analyst that have been very much involved in designing the methodology to estimate the nutritional top-up part of that package. And I'm also with Sarah Bernardini, which is our nutrition sensitive social protection specialist. And Sarah has been partnering with a groundwork to really deep dive into the M&E, setting up a robust M&E framework. By the end of the session, we hope that you will be able to recognize the value of cash and voucher assistance for prevention of acute malnutrition as a main tool for achieving nutrition outcome within emergency settings. We hope that you will be also able to identify settings, stakeholder processes that are required for the implementation of a CVA for prevention of acute malnutrition. We also want to make sure that you're going to be able to describe and distinguish the key components of that package. And particularly, we will be zooming on transfer value, social behavior change activity, and also M&E framework. And finally, because we've been piloting that approach for some months now, we have started getting a better sense of what are the minimum requirements, or at least what are the strong learning cross-context that we've got for designing quality cash programming for nutrition. This 2-hour session will be structured in 4 parts. So the first part, I will introduce and present the latest evidence in the use of cash and voucher for nutrition outcome. The second part will be dedicated to presenting WFP cash prevention approach. The third component, as I said, is going to be about deep diving, and you could pick up one specific topic of your interest and you will be able to join a group. Group 1, Chris will take you through the different steps to estimate the individual nutritional top-up. Sarah will let you know the work that we've been doing, as I said, to set up a robust M&E framework, while Dexter will talk you through the different steps to plan and implement an effective social behavior change, and particularly what it means in a context of emergency. The fourth part will be dedicated to Q&As. So yeah, the use of cash and voucher assistance in humanitarian settings has steadily increased in the last decade, with humanitarian funding spent on CVA raising from $2.8 billion in 2015 to $6.7 billion in 2021. So this makes up nearly almost 20% of total humanitarian funding. Majority of that CVA's, cash and voucher assistance or cash-based transfer, has been used to address food insecurity. But there is an acknowledgement that we need to better integrate nutrition to make sure that we are able to scale up the use of CVA to address malnutrition. So a huge uptake in the use of cash, but not necessarily reflected for nutrition, let's say. We also have a landmark, in a way, publication in 2020, the Global Nutrition Cluster issued an evidence and guidance note that collects and affirms that CBT, or cash-based transfer, can contribute to improving maternal and child nutrition. While there is consistent evidence available on the positive impact of CVAs on the underlying determinant of malnutrition, such as improved food insecurity, household consumption, dietary diversity, there's a little bit more mixed evidence on the impact of the nutritional status, and the context really matters. But we now pass the stage of the pilots. We need now to be able to put at scale robust CVA program for nutrition. And yes, those numbers are really dull, but in 2023, WFP estimated that 345 million people need urgent food assistance, while the number of acutely malnourished children is on the rise. Globally, 60 million of children were estimated to be malnourished, wasted, as of 2022, compared to 47 million in 2019, before the COVID-19 pandemic. So given the magnitude and the complexity, there's an urgent need to be able to expand our toolbox, expand our approaches to prevent acute malnutrition. You may be familiar with this framework. This is the UNICEF conceptual framework for malnutrition that identify the immediate, underlying, and basic determinants of malnutrition. And what we know now is that cash and voucher can indirectly act upon the immediate determinants of malnutrition, meaning diets and disease. But we also know that this impact results because the CVAs can impact the underlying determinants of malnutrition, meaning like the food security. We can also improve care and health thinking and feeding practices of nutritionally vulnerable group. We know that it can sustain or increase household food and income throughout the year, and consequently minimize the use of negative coping mechanism. It can also reduce household tension and economic pressure while enhancing decision-making power of women. So CVAs can really impact both immediate and underlying determinants of malnutrition in multiple ways. So these slides capture the latest in terms of evidence-based program feature. I already mentioned the Global Nutrition Cluster evidence note in 2020, but there is also a couple of key publications that really showcase impact of cash. The first one is in 2020 by Scott that shows that cash transfer are identified as the second most cost-effective intervention following vitamin A supplementation for reducing wasting. While there is also a meta-analysis that was done by Menley in 2022, showcasing significant positive impact on stunting, wasting, and diet, and decline in the incidence of diarrhea. In terms of targeting, we know we are now quite aware of the importance of the 1,000 days to be really able to have the greatest impact on child nutrition outcome. But we also know that prioritizing women is already has greater impact on nutrition because women will more likely put money into the well-being of the child and the food security of the child. We also understand now much better that cash by itself is less likely to achieve the desired impact or effects. So it's really important to couple that with some strong social behavior change activities to really have to benefit child growth and maternal nutrition. The evidence that we have, please, yes, thank you. The evidence that we have also really talked about sub-Saharan and Africa, including conflict setting, which is very important as well, given at the moment the level of protracted crisis, but also the number of conflicts on the rise, unfortunately. In terms of frequency, we know that predictable, regular, and frequent transfers are more likely to have an effect. And we can also, in protracted crisis, consider longer program to be able to sustain that impact. So in 2022, in September 2022, WFP released interim recommendation to support the use of cash to prevent acute malnutrition in the context of global food crisis. Why we released those recommendations? We needed to be able to respond and expand our toolbox because we had an increased shortfall of specialized nutritious food to prevent acute malnutrition in humanitarian settings. But we were also cognizant of the fact that the evidence base is growing and is more significant. So we released the interim recommendation, and they were piloted in a couple of countries, only in places where actually markets were functional. And this is a really important component that I will be further elaborating on. Our work in different settings, we wanted to make sure that we have clear parameters on the use of those guidance. First of all, we really want to make sure that obviously we want to focus on prevention of acute malnutrition in context where, as I said, the use of specialized nutritious food could be constrained, but where markets were functional. And when to use those interim recommendations, we kind of put our decision based on the Global Nutrition Cluster MIME decision tool. I'm not sure if all of you are familiar. It's actually was released in 2013, and that indicates that when global acute malnutrition prevalence is high, above 15%, or medium, between 10 and 15%, and in presence of aggravating factors such as disease incidence, population displacement, density, and food insecurity, we're making decision in terms of like type of nutrition intervention that needs to be pursued. We made very clear when, where actually use and implement those interim recommendations. And it was very important to be context specific and really making sure that three main preconditions are met. First of all, understanding how economic barriers prohibit access to nutritionally adequate diets, and that can be addressed through cash-based assistance to increase the household ability to purchase and consume nutritious food. I already mentioned how much markets are functional, but really we needed to make sure, and we need to make sure that the market provides sufficient availability of nutritious and at age-appropriate food. And lastly, we need to make sure, obviously, that national policy and framework regulation do not impose any restriction on the use and the value of cash for nutrition programming, and that there is no donor restriction per se. Our target group are very much around targeting the nutritionally vulnerable group, meaning the children under 5, pregnant and breastfeeding women and girls. Obviously, in context with limited financial and logistical resources, we may need, and where we need to prioritize, the target would be restricted to children aged 6 to 23 months. So based on the available evidence, WFP recommend the following package for the prevention of acute malnutrition in highly food insecure area. First of all, we want to make sure that we ensure that households are food secure and receive some food assistance. We will complement that household food assistance with individually targeted nutrition top-up using cash-based transfer to meet the specific nutrient needs of most vulnerable target group, as I mentioned already, pregnant and breastfeeding women and girls, but also children under 5. We want to make sure that there's systematically a robust, tailored social behavior change component to really nudge or guide on the use of the top-up through the promotion of optimal infant and young feeding practices, but also maternal nutrition and health thinking behaviors. And finally, we really want to make sure as well that part of that package, there is a strong component of nutritional screening, early detection, and referral mechanism to health and nutrition services to make sure that we are able to diagnose acute malnutrition timely. These interim recommendations, as I said already, were piloted in a few countries, and one of our colleagues from WFP went in Somalia in October 2022 to really put in place, step by step, put in place of the interim recommendation and see what was the experience, the challenges, and the emerging learnings that we could get out of those. So when we design a cash intervention for nutrition outcome, actually, we tend to follow the same steps that are taken for any type of project. So first of all, we need to assess the needs, but also engage with community to understand their preferences. But in the case of cash for nutrition, we need to understand if the use of cash is feasible, suitable, and appropriate in such context. And I will speak a little bit more about that. Obviously, the second stage is to design and plan the intervention, including the budgets, identifying the right partners, but also identifying the risk of running such a type of project and making sure that mitigation measures are well thought through ahead of time. The third component is around the setup and the delivery, while the fourth one is around making sure that we are able to monitor and review along the way to ensure cost correction. And this is particularly important because in WFP, we tend to have heavy monitoring system, but not necessarily at the frequency that we need to be able to cost correct. So that was particularly something that we work out. Not to mention as well that we are working not in a vacuum, and there's a lot of coordination and communication that needs to happen from the early stages with all the stakeholders that are involved in CBAs, but obviously our government counterparts. I did not mention, but obviously those interim recommendations can be also used by governments if need be. So the first question that we ask ourselves, and even though it could be somehow a rhetorical question, was that do we need prevention intervention in Somalia, given the context? And as I said, the nutritional situation in Baidoa was really bad. The GAM rate, the global acute malnutrition rate, was at 28%. That was in October 2022. And we used the global nutrition MAM tool to be able to gauge or assess the risk of deterioration to be able to get a score. So we knew at that time that there was the IPC, the Integrated Phase Classification Food Insecurity for October-December, projected that 90% of the population of Baidoa was either in IPC3 crisis, IPC4 emergency, or IPC5 famine, with rains anticipated to fall for a fifth consecutive season. Mortality was also exceeding emergency threshold, and morbidity as well was very high, particularly in IDP camp, 43%. One of the reasons why, because the morbidity rate was very high, was because the measles vaccination and the vitamin A supplementation were very far from the sphere standards and were very low rates. There was also reported cases of cholera. So all of this analysis show us that we're scoring very high in terms of risk deterioration, and we definitely needed both treatment and prevention intervention in that context. So the next question that we ask ourselves was really, okay, now is cash for nutrition feasible, appropriate, and suitable in Somalia? And we may say that in some contexts where there's very high level of food insecurity, it seems to be a bit crazy, or at least really difficult to see how can we do and can we use cash for nutrition. So we have a number of feasibility assessments to help us making and informing that decision. The first one is really related to the market functionality index. So you could see on the left-hand side, there's a map with some colored dots. This is where I've been actually assessing market functionality. It's a tool that have been developed by our colleagues from supply chain that looked at 9 components of the market. So obviously availability, prices, assortment of goods, the resilience, the infrastructure, and then you will get a score that will let you know about how much market are functional. And obviously coming with a high level of risk or not, and mitigation measure. So for Somalia, we make sure that this MFI will speak to nutrition by making sure that we were looking at some very specific nutritious food. The weekly price monitoring of food commodities as well is something very helpful, and Chris will let you know more about in terms of estimating the transfer value. But it's very important to be able to collect on a regular basis prices for nutritious food, including different food from different food groups, animal source food or vegetables, legumes, rich on vitamin A. So it's important to have that monitoring to be able to also course correct. Because our CBT operation were already ongoing, we didn't need to go through the financial service provider assessment. We actually were building off our CBT intervention. So I'm not going to spend a lot of time on that. We wanted to make sure that that was also beneficiary and community preferences. So we ran a quick assessment on that, and it was clear that people were keen to receive cash for prevention of acute malnutrition. And we also try to understand better as well and map out all the health systems and services that were functioning to make sure that we could refer our potential beneficiaries, particularly children, to the health facilities for supports in case they're falling into malnutrition. One of the things as well that we were keen, obviously, as I said, we're not in a vacuum, so we wanted to make sure that this aligned as well with our colleagues working in CVA, so the cash working group, but also obviously our counterparts from the government side. Finally, the minimum expenditure basket really is usually very much used to inform the transfer value of multipurpose cash. So we wanted to understand how much nutrition was factored into the minimum expenditure basket for Somalia to get a sense of if we were it was well lined. So all those assessments were put together and discussed among colleagues, and we then decided to go ahead with that program and design, as I said, a package of intervention. It's not just one standalone one, but it's really making sure that vulnerable households will receive that package. So relief, which is really the cornerstone of our strategy to make sure that family can access food sufficient in quantity, in quality, and really is a central piece of the package. We want to make sure that we have individual nutritional top-up to really cater for the specific needs, even though the general food assistance or the relief will be nutritionally adequate, it will not be sufficient to meet really the specific needs of our group. So we want to make sure that there is this top-up to cater for those needs. And then, as I said, some specific social behavior change and linkages to health facilities. So once you design as well, as I said, once you've done all that feasibility assessment and you're ready to move forward, you need to make sure as well that you're very clear on some key features of your cash programming. Obviously, the modality, are we using cash? Are we using voucher? What is going to be our delivery mechanism? What is going to be the duration and frequency of assistance? And what will be the transfer value of that top up and how to estimate? So you could see that here we had a different top up for when you calculate for under 2, for children under 2, and for pregnant and breastfeeding women and girls. We decided to go for a flat rate, and that $35 US, in addition to the general food assistance, will be given to the household for that nutritional prevention program. Recipient will be women within the household. You also have to make sure that you're very clear on the registration and enrollments. And one of the challenges that we face is really about the targeting and how to make sure that you speed up that process. And finally, as I said, because it was a pilot, we have a very robust M&E with a very strong baseline, midline, endline, and regular monthly monitoring and the post-distribution monitoring. We've also outsourced actually the social behavior change to make sure that we have a robust formative research and strategy development. So I've already touched upon a little bit, but in terms of design and in terms of implementation, we've been learning, and I particularly focused on Somalia, but we've been using those interim recommendations across different contexts in the Sahel, in Burundi, in other places. So we tends to have now a good understanding of really what needs to be put in place, particularly from the outset, from the design stage. We need to factor in that assessment are obviously very much required and are time consuming. And this is particularly true if we want to make sure that we increase demand for nutritious food. We need to perhaps also stimulate some markets to make sure that supply is available. So this takes time. Those market-based activities takes time. This is also very true if you need to leverage private sector. And this has to be factored into that from the very beginning. In terms of design, we have really clearly listened the fact that we need to be able to budget adequately. It's not always easy to budget a social behavior change component, particularly in emergency. We also need to make sure that there's sometimes a little bit of it's complex to think through all the sequencing of all the complementary of activities, because all of them needs to happen in a very specific way and not necessarily going to be implemented by the same partners. So you also have to build the capacity of that partners to make sure that you have then the activities implemented all together. We also know that registration of beneficiaries is time consuming.
Yes. So the attendance is going. So today we are.
Is it possible to mute? Thank you. One of the things as well that Chris will talk about is like once you have estimated your transfer value, and how do you handle with all the price volatility and the inflation that we've been going through, and how do you factor that into your transfer, because this has to be taken into account as well from the very beginning. In terms of implementation, obviously in contexts where we work, it might be very tricky to have nutritious food available all year long. And in one same shop, actually, you want to reduce time for people to get to market, and so obviously those are considerations that needs to be taken into account, or making sure that you have identified substitution in case the product is not available. And really connecting demand and supply all together takes time. As I said, there's always, we are working in contexts where insecurity, not necessarily, the insecurity could be very high. So you also have to handle some population displacements and making sure that you don't put people at risk. There's always some kind of tension between getting the transfer done according to donors, but also the operational context and constraints. And if you need to also make sure that you collect robust evidence. Finally, on the M&E side, we also know that it tends to be not necessarily budgeted enough. Again, we want to make sure that we are able to showcase results. And so it means that we need to make sure that we have minimum investments. And we have come up with a tool, what we call the program impact pathway, to really help designing the right intervention with the right set of indicators to be able to measure our progress along the way. Sarah will talk you through more about that. Overall, you need time and you need to resource and you need to really plan and resource well, and really making sure that you learn and you're able to course correct as you go. Now to go into the deep dives. So as we said earlier on, you have the opportunity to select a group where you can learn a bit more in terms of how to do it. Welcome back, everyone. I hope you had a fruitful discussion, and I'm very pleased to see that we already have so many questions as well in the chat. So first of all, I'll ask each of my colleagues to report back in 5 minutes what will be the key takeaways from each session to make sure that everybody is on the same page. Chris, over to you.
Thanks, Geraldine. So the key takeaways on the session on estimating a transfer value for nutritional top-up were the fact that we can utilize information from the estimation of transfer values for household assistance to inform our calculations. So we can utilize existing information that in a given context from the cash working group or partner organizations to inform the nutritional top-up calculation. The calculation has 4 steps. Firstly, estimating the cost of meeting nutrient needs for recipients. Secondly, understanding how much money a household spends on food. And then calculating the gap between diet cost and what households can meet themselves. And finally, what proportion of the remaining diet cost is met by household assistance. We ran a little bit over with the presentation, so we just managed to get into some of the stickier and maybe more interesting questions around when we actually have a value, what we then do with that value. So whether we use a flat rate for all individuals in the household, whether we have a cutoff on the number of individuals in a household who would receive a transfer, when and how often the value should be updated, especially in high inflation contexts. So we just discussed a little bit some of those issues, and hopefully we can also bring some questions on the session into the main plenary here as well, that we didn't get around to addressing in our session. Thanks.
Thank you, Chris. Thank you, Chris. I'm sure there's a lot to cover anyway. 40 minutes to time is kind of like reduced. But yes, please, everybody put your question in the chat so that we can answer them in plenary. Turning on to Sarah. Sarah, can you tell us a little bit more about the key takeaways in terms of like setting up a robust M&E framework?
Sure, thank you, Geraldine. So unfortunately, even our presentation, we were not able to get a question at the end. But just like to give a kind of a review of what has been discussed. So basically, I presented some of the evidence that we used to inform the package. So explain that the package that we have designed was coming up from this programming pathway that has been developed using the existing evidence, showing that by how just giving a household assistant is not enough for achieving nutrition objective, but there was the need to add a specific component at time. One is the individual top-up, complemented with SBC, but also the linkage with the health system. And this is mainly because WFP main entry point is toward the food intake pathways. And this is kind of like our kind of comparative advantage. So we explore the programming pathway, mainly looking at that, but we don't want to ignore that we have other key components that can at the same time contribute to achieve prevention of acute malnutrition. I also introduced some of the indicators that we map out and we selected from a bigger list of indicators, and we consider as a minimum package of indicators, and we feel are really important to tell a story. Include a process indicator, output indicator, outcome indicator, and I present those that we have identified internally, explaining the reason why behind. I also explain the importance of budgeting the M&E. Otherwise, it's really difficult then to have enough resources for a good M&E. And I anticipated that in the context of Somalia, we also felt really important to have a baseline, an end line, and midline, because we want to really to inform the programming, but at the same time, if possible, also increase global learning. And I think like I finished by saying like it's really important to have regular collection of data, because that can allow to core correction, but at the same time also inform like advocacy, evidence building, etc. So that's all from my side. Thank you.
Thank you, Sarah. And actually, I see in the chat that there's already a question on breastfeeding in terms of measurement that we will talk about later on. Thanks. Dexter, I'm sure the SBC also session was very lively. Can you tell us in a couple of minutes what were the main key takeaways?
Thank you, Geraldine. I think like both the other sessions as well, we didn't have a lot of time to dwell into questions, but I think the main takeaway points when it comes to SBC, it was just like to look at when you look at SBC and embedding it within a cash for prevention program, you need to carefully plan and also address the issues on demand and supply barriers. to actually achieve the optimal nutrition practices that you want. And in most cases, we then realize that what's more important is having that well-sequenced SBC and cash effective cash activities, which is very important because you then really look at some of the key barriers or key facilitators for improved nutrition practices. They usually come from other assessments that are linked to the design or the preparation of cash for prevention. And in most cases, when you then have SBC as a parallel program or as an afterthought, you then miss the actual components that you have to address within a program. Then we also realize that when you're looking at SBC goes beyond our traditional information, education, and communication. It's not necessarily the messaging. It's not necessarily the mass media messages only. But now you then have to link it with other activities, which is peer-to-peer, mother-to-mother support groups that will then have certain behavior change activities to facilitate behavior change to work we want. But we also realize that formative research is very critical, especially to determine if your intervention will be successful or not. And I think there was a lot of questions around the formative research, because in most cases, formative research, we look at it as a longer process, an expensive process. In most cases, how then do we apply it within an emergency context, especially in the case where we have our cash for prevention programs? It's just a short period of time. That is not adequate amount of time to do your formative research. Could be an in-depth barrier analysis. Do we have ideas of other methods, especially a rapid or a light touch formative research that we have discussed about? So we then realize that within 3 weeks, we can actually be able, within 2 to 3 weeks, we can actually be able to do a rapid formative research that adequately informs our cash for prevention program as well. Then we also went on to demystify the SBC strategy. That is not necessarily a 30-page, 40-page, 50-page document or the case, but an actionable plan, which could be a few pages that can guide or inform your action as well, which becomes very, very important. Then the last point, SBC has to be budgeted earlier on. In most cases, we think of it as an afterthought. In most cases, we actually do not realize that it actually needs funds. So we then realize that in our case, especially in WFP programs, we've realized it takes about 15% of our budget, sometimes 30%. But when it's rapid, you can actually have it within a very short period of time with a low budget as well. But it has to be well budgeted when you design your program and well sequenced in your cash for prevention program. I think those are the key points or key takeaways that we covered today. Thank you, Geraldine.
Thank you, Dexter. Thank you, Chris, and thank you, Sarah. So now we're going to go through the different questions that were put in the chat. Thank you so much. So I just want to first to clarify a few things, because perhaps as well, it's always a little bit confusing in terms of terminology, what is meant when we talk about cash-based transfer or cash and voucher assistance, when we talk about restriction versus unrestricted cash. So let me clarify, because there's a couple of questions actually related to that. So already asked a question about the difference between CBA and CBT. I suspect it's CBA, the differences. So it's actually just a terminology matter. So cash-based transfer, or CBT, includes all money or value entitlement transfers, which are either unrestricted money or restricted, what we call value vouchers. They can be delivered in physical form, cash in hands, or electronically onto digital wallets and mobile money accounts. So CVA just stands for cash and voucher assistance, and it's another terminology that we use. So I hope it clarifies. Then I'm just gonna also take another question from Angtu Chai, which is asking about the difference between the terms conditional, unconditional, restricted and unrestricted. I want to make sure that everybody understands and is on the same page, because those are important concepts. So when we talk about conditional cash transfer, we actually mean that you have to comply or fulfill an obligation. The recipient has to fulfill an obligation in order to receive the assistance. So this can be there could be conditionality used with any kind of transfer. It doesn't have to be just cash. It could be voucher, but it could be also in kind. So it really depends on the intervention design and the objective. For instance, we could say that when kids are going to school and there's school meals provided, this is upon conditionality that they get the school meals. Or you could actually receive some conditional support if you attend some kind of nutrition screening or you undertake specific work. Once we have that condition that is set according to your program objective, this one can be either what we call strict, meaning like you really need to comply if the recipient can get the entitlement, or it could be soft, meaning that it doesn't really matter if the recipient miss 1 or 2, it would still receive the entitlement. From a WFP perspective, particularly in emergency, we don't use conditionality. We use soft conditionality. The household will still receive the assistance, even though they are not able to attend or participate in some activities that have been defined. When we say unrestricted and versus restricted, when we say unrestricted, we talk about money only. Meaning like people that are assist have no limitation on the way they are going to use the transfer. They can spend the money as they deem appropriate. They can purchase food, they can pay the rent, the bill, they can repay loans. So it's really upon their decision. When we talk about restricted, we're talking about a value voucher, meaning like the entitlement that recipients are going to get, they can only use it in certain shops for certain goods for a limited amount of time. So this is what we mean by restricted. And I hope it clarifies, because sometimes it could be tricky to understand. There is a question that I'm actually going to give Dexter the floor from Shizomo, and asking how can social behavior influence the nutritional status of an individual?
Thank you, Geraldine, and thank you for that question as well. And I think this is a very, very important question, because I think when you then look at the goals for the cash for prevention, what we then want to improve nutritional status, we want to prevent malnutrition, and social behavior change comes in as a catalyst, because you're following the pathway of optimal nutrition practices being employed within a household that's actually receiving the cash-based transfer. So the pathways generally will then look at the household utilizing the cash that they have received to start to access those diverse, nutritious foods, whether they are being consumed by an adult, in our case, pregnant, breastfeeding women, or being fed to children as part of complementary feeding or IYCF. The other pathway that you also see is, as well, when you look at SBC, it then facilitates for the household to demand for certain services or access certain services, which could be healthcare services like mass screening of malnutrition, early detection of malnutrition and early referral, then also access to malnutrition control programs or micronutrient deficiency prevention programs. So you then see SBC is coming in as a catalyst to ensure that these households that are targeted for cash for prevention program actually demand the services, actually access the services, and can actually employ the services within the households. Then also another component that's really important when it comes to SBC, it smoothens out other key barriers. For instance, in most cases, when households actually receiving cash, I think within our Yemen experience, we then realized that there's a lot of gender-based violence which comes in, which also relates to increased cases of increased malnutrition, especially wasting. You then realize that when you utilize your SBC, you can actually design SBC strategies that take the form of gender transformative approaches, and you can actually include gender transformative processes as part of your SBC as well. So SBC improves nutritional status from these various pathways. I hope you've been answered. Thank you.
Thank you so much, Dexter. Yes, I'm actually going to turn to Sarah for the next question, because obviously it builds upon the social behavior change component that Dexter just mentioned. But there's one question from Christelle about how can we be sure that the cash given to household will be really used to that end for nutrition and health. Sarah, can you tell us what could be the monitoring that we could implement to support and ensure this is going in the right direction?
Yeah, thank you, Geraldine. Thank you for the question. So this is a really important question. And of course, like SBC, it's key, especially when multi-purpose cash is provided. So that's why when we discuss about the M&E, we discuss about different indicators that we can collect across the pathway, let's say. So of course, we look at an indicator in terms of like the adequacy of the transfer we are providing and the timeliness of the transfer that we are providing. So to check the quality of our programming as well, meaning that you provide the households, plus you provide the individual top up. Okay, are you providing individual top up timeliness in a timely manner? It provided as planned in terms of value, because if you have any deviation, you won't be able to expect to achieve the objective that you have set at the beginning. So this is what we call process indicator, because they're meant really to look at the quality of the implementation. But then another step is to look from the output perspective, whenever feasible, how households are using the money for. So you can ask, like, for example, what type of food people have been purchasing, if they're purchasing food or using the money for something else. And usually you do like with survey, but if you use specific tool, and in WFP, if we use some like electronic tool, you are also able to get information through post data, for example, but it's not always feasible. But you can check what people are reality buying, and it's already give you a kind of idea. And then the outcome indicator, what you are like expecting to see if the kind of like change in the diversity pathway. So we are expecting that if people are using the money for purchasing food for vulnerable groups, the diversity of kids and women in particular are gonna change. And so this is how we normally trying to build our M&E to reflect if there is any change in the use of the individual top up. Yeah, that's from my side. Thank you.
Thank you, Sarah. Thank you so much. Chris, I'm going to turn to you now. We have a question about the inclusion criteria for the intervention. So I understand from Medby that the question was like, what were the inclusion criteria for the intervention? Let's say that in a household, you have a pregnant woman as well as an under two child. Would the amount and top up be different for this family? And I want to link that question as well to Sammy's one, because Sammy is also asking that CBT, CVAs are great intervention because they let people meet urgent needs. But how do you decide which household will benefit more from CBT than direct food relief? Are you able to tell us a little bit more about those two aspects?
Certainly, thanks, Geraldine. So on the eligibility criteria, it's a really good question. I can't say that we have really firm advice. I think it depends on the program itself. So when we calculate transfer values, we calculate them for a pregnant breastfeeding woman or girl and children under 2 or under 5. When it comes time to implement, if a program eligibility is for a woman from pregnancy through the first 6 months of breastfeeding, then at 6 months of breastfeeding, a child becomes eligible, and then the transfer is given to them. We do not recommend to give separate values for those 2 individuals. And the core concern there that leads to that recommendation is that breastfeeding should continue after 6 months. There's increased nutrient needs and dietary costs associated with that. So it's not a good idea to give a woman one value, which tends to be quite higher, right? It's a lot more expensive to meet the nutrient needs of a woman than a small child, especially a pregnant or breastfeeding woman who has, highly elevated nutrient needs and dietary costs. So we recommend to give, if giving a flat rate, to give a higher value of the dietary cost of the pregnant and breastfeeding woman or girl, and to sustain that through the first 2 years of life, of the child. If it's possible to give more than a single transfer value per household, then the additional members of the house, the additional children, most likely in the household who'll be getting the nutritional top-up, we can use the dietary cost of the child to estimate a transfer value for the additional children. When the eligibility criteria are set for children from 6 to 59 months or under 5 years, it's quite possible that you're going to have multiple children in a household within that age group who will be eligible for the program. So you will need to give additional values per child. How many individuals in a household we can actually provide transfers for is a question for each individual program, depending on the resources available and depending on the capacity for enrollment of individuals. So it can be quite difficult to actually keep track of all the number of children under 5 in a household or in a population, households with, a given number of children under 5 within households, calculate that value, provide it to the households until the child is no longer eligible. So that can be quite difficult. And because of that, it may be a case that, and due to financial constraints, that you can only provide a flat rate per household. But yeah, that's really the recommendations that we have in terms of the eligibility criteria, whether to use a flat rate, whether to give it an additional top up for each individual in the household. Ultimately, those questions very often become questions around resource allocation and whether you want to have a larger population eligible for the program with maybe a more reduced number of beneficiaries per household, or whether you want to have a large number of eligible beneficiaries per a flat rate and cover more households with that flat rate. So it's really a question for the specific program, and I don't think it's possible to give universal recommendations on that. What was the second question, Geraldine?
It was about to make a decision in terms of like modality. How do we go for either relief or in-kind food assistance or CBT? Mm-hmm. I guess this is really linked to the modality and the assessment.
Yeah, so for household food assistance, the WFP has a number of tools which guide us in making those decisions. A core one being the market functionality index, so understanding if markets are functional. Geraldine briefly touched upon this. We have a number of dimensions on which we assess markets. In terms of for nutritional top-ups, whether to provide, say, specialized nutritious foods or whether to provide cash, I think it's a tricky question. We don't have specific recommendations around that. We recommend really to use SNF where possible, if they're depending upon the supply constraints in a given context. So at the moment, there's often supply constraints around SNF, both in terms of accessing and having a steady supply of it. So in those contexts, we would recommend then to take a market functionality assessment, understand cost of meeting nutrient needs, and then make an informed decision.
Thank you, Chris. The next question was actually for Dexter. You mentioned it a little bit during the key takeaways. Dave, if I'm not mistaken in the pronunciation, I put in advance, wanted to understand it can be very difficult to do formative research by analysis in an emergency context. Do you have example of rapid formative research for SBC? You already mentioned what's feasible in 2-3 weeks. Can you tell us a little bit more about that?
Yeah, thank you, and thank you for that question. Yeah, I think in most cases we've seen a lot of I think a lot of folks becomes more comfortable with barrier analysis, because in most cases the eventual goal is to identify those social drivers for nutrition practices. In most cases, your barrier analysis tease out your key barriers, your main facilitators, and a lot of people are easy. But in the context of an emergency, it becomes difficult to then want to be able to carry out a full-fledged barrier analysis. So within WFP, we use a package, especially for countries that or circumstances that are within the emergency. So we have what we call a light touch formative research, or a rapid assessment, formative assessment, which comprise initially of a desk review, because you already have, especially when you have good data, good evidence, a lot of assessments. Then what you can also do, you can actually have a rapid qualitative assessment that you can employ within 2 or 3 weeks, where you have your consultations with communities, key informants, focus group discussions with key group population groups that you are targeting, so that you unearth those social norms, cultural issues, gender dynamics. Then in some cases, we have also had experience where you can actually do informal consultations, where you speak to different people as they are going through mechanisms to then be able to settle, especially when an emergency is actually happening, where you're trying to understand the key barriers and key facilitators. So you can actually design your rapid assessment in the form of quantitative data, in most cases secondary data. Primary data, you utilize a lot of qualitative data from transit walks and then informal consultations. I think those are methodologies that you could employ during an emergency over a short period of time. Thank you.
Thank you, Dexter. Thank you so much. So mindful of time, I'd like to ask Sarah, there's a question around the modality that we're currently using, the transfer modality that we use in Somalia. This is a question from Myomin Kyo. What are the challenges of the selected modality? And if it is the eCash, could you please share your experience? Maybe Sarah, can you share with our participant what we've been trying to do in terms of impacts and evidence generation, trying to actually compare different modalities? Over to you, Sarah.
Yeah, thanks, Geraldine, and thanks for the question. So I think it's really important, this question, because actually we mentioned that it's really important in market assessment. It's really important to look at what is available. Sometimes it's the donor and the government deciding what they want. And this is like the situation in Somalia, for example, which we have some donor that are actually willing to use voucher, some donor that wanted to have a specialized nutritious food, and some donor that wanted to have multi-purpose cash. So for us, this was a very good context because it allowed us to set up a randomized control trial in which you are actually comparing the evidence and the impact on nutrition, on prevention of acute malnutrition between in-kind, cash, and value voucher. So as I said, from a learning perspective, this is really a favorable context for us. But just to flag that when we think about transfer modality, most of the time we tend to look at the programmatic aspect. but sometimes there is something beyond that actually dictate what you have to use, and having evidence at hand that can actually kind of influence the decision. It's also an important point, an important step. For example, when you engage with the government or when engage with donor, because not all the time the decision is necessarily taken by looking at for example, in our context, in market. So in the context of Somalia, of course, the market was assessed, and it was seen that it was like in specific in Baidoa was a context that allow us to use the different type of modalities. But I think was a really important opportunity to have the three modalities at hand and be able to do this kind of like comparison. And so we hope that in 6 months, we are gonna have some evidence showing like what is the different impact on prevention of acute malnutrition by using cash versus in kind and versus voucher. I hope my question was clear and responded to.
No, thanks, Sarah. Indeed, we have, I mean, Somalia is a complex context, and you actually do not necessarily have like one size fits all for many good reasons in some places where markets are not functioning, where you have donors restriction. So we've been trying to assess what would be the best modality and what would be the results. So there are decision trees that exist to support on the modality decision. What is really important is to document and keep track on why the decision has been taken, because conditions and circumstances can change, and you may have actually to switch from one modality to another. So there is a question around the longer term sustained impact from Julia, which is a really good question. How do we ensure that we have a long-term sustained impact after the implementation of the program? So what we presented are obviously is usually what we do in emergencies, so for a very short period of time. And what we've been trying as much as possible is still, when possible, to link it to national social safety nets when it's possible, or to expand through the use of social registries, or through advocating for the government on a very specific transfer amount. So we always try, when possible, to link that to a nationally led schemes. But we also try to approach that from a food system perspective as well. I talked about the importance of also stimulating markets. And once we have a good understanding of how the dynamics of the market for nutrition, we can also try to think a bit more longer term in terms of like investment along the value chain, making sure that there are more supplies of nutritious food, support and working with private sector when possible to develop a local food solution. So there are many ways to support and strengthening somehow the sustainability. Obviously, once you have a very limited and resource and let's say funding cycle, it's always a little bit difficult to build that from the outset. But more and more, we're trying to link to our resilience and our food systems and broader social protection assistance. So Senat wants to ask, how was the breastfeeding outcome indicator monitored? Nyasha wants to understand a bit more the link between the mortality and the cash distribution, because the presenter indicated that there were not much improvement in terms of reduction of mortality and the intervention. Was this mortality recorded at hospital level or specific to household that were given cash? And this is also linked to the minimum acceptable diet and the minimum meal frequency that are usually difficult to collect data at individual level due to the lack of monitoring at health facilities and the need to strengthen collection at this because the indicators do exist in current register. Was the data collected through a survey?
So maybe I can respond the breastfeeding and MDDW and MAD together. So WFP usually do data with post-distribution monitoring. So our household survey, especially for MAD and MDDW, we normally tend not to do health facility level. The breastfeeding can be done at health facility level whenever you have a very strong health staff. Otherwise, again, is done by our M&E colleague at household level. So meaning when they collect, for example, the food consumption score, they also collect information in terms of breastfeeding practices and MDDW and MAD. This is like how WFP normally approach, because we consider we are very well aware that our health staff normally are really stretched and overburdened, so they won't have time also to collect this type of capacity. Maybe they don't necessarily have the capacity of collecting these in data. So this is what we normally do. And for the breastfeeding, we refer to the WHO IYCF guidance that was recently released in terms of methodology. And there are a few indicators that are listed, and you can pick the one that you feel more pertinent, like, for example, excluding breastfeeding or like early breastfeeding status, and there is the methodology that you can follow. In terms of mortality, I already responded in the chat. So what I wanted to say is like that is like limited evidence, meaning that it hasn't been investigated yet much in terms of linking between cash and mortality. So I included in the chat some of the information that we found. There is some information in relation to, for example, there's used perinatal, neonatal, and child mortality. But as I said, we couldn't find many articles that are actually reporting that type of linkages between the cash and the mortality, and mostly because, as I mentioned in the session, most of our evidence is referring to household cash. There is very little evidence around top-up or nutrition objective. Most of the time, all the evidence that come from households cash distribution, so even National Social Protection Program, and mortality, if there was evidence coming from Brazil, for example. So most of the time, it's not meant with the nutrition objective. So this type of indicator are not part of the monitoring system. It's only sometimes maybe because they have seen some linkages, or maybe they have seen some correlation, they thought to have more information around that. I hope it's clear, but as I wrote in the chat, I have more article. We can even discuss bilaterally. I'm very happy to share all the information that we were able to get. And I'm sure there is even more. Thank you.
Thank you, Sarah. Time flies, so it's already time to close our session. I'm aware that there's a few outstanding questions that we will respond in the chat. I really want to thank you, all our participants, for the great enthusiasm and interest in our session.